So let me share with you another challenging case. Uh, so what I'm going to do is take you through from appendix all the way to the rectum. So here we see the ileocecal valve, and there's quite a bit of fluid here. We suction the fluid, and then we find our first sessile serrated adenoma. So as the video is flowing, let me share the case history. This is a middle-aged patient who was found to have, on screening colonoscopy, a large polyp in the descending colon, and she was referred for resection. She went to see another endoscopist who found another large lesion in the ascending colon and then referred her for uh, endoscopic mucosal resection, or ESD. When she came to see me, I decided to do a repeat screening exam to define the disease burden, and in the ascending colon itself I found 4 sessile serrated adenomas. This is the third one, and as you can see here, she has done an excellent colon prep using a split dose preparation. Split dose preparation involves taking half of the dose the evening before. Typically in our practice, we encourage them to take it around 3 o'clock so that they can sleep, and then take the second dose 5 to 6 hours, finish it 5 to 6 hours before their appointment for colonoscopy. So this tattoo was placed by her previous colonoscopist to mark the site of the large sessile serrated adenomas. So far as we are coming down the colon from the cecum, we have noticed 3 sessile serrated adenomas, and all of them proximal to that tattoo. And here you notice the 4th sessile serrated adenoma. So when you see a patient referred for resection, before you go and resect straight away, it is a good idea, if you have suspicion as you go in about having lesions that have been overlooked, it's a good idea to make an assessment of the total disease burden, so that you can have a game plan for management of sessile serrated polyposis. This is what this patient has: multiple large sessile serrated adenomas. If the disease burden is heavy, with sessile serrated polyposis on every other fold, that is quite impossible to resect with colonoscopy, and in that case surgery is preferred. On the other hand, if the sessile serrated polyposis is not particularly that dense in its distribution, one could think about endoscopic resection, but it will require multiple procedures at 3 to 6 month intervals to clear all the polyp burden, following which the patient requires colonoscopies either at yearly or 2 yearly intervals. So we've gone through the cecum, ascending colon on the right side, and we turned around the hepatic flexure and we entered the transverse colon here. So as you can see here, the preparation is excellent, and the preparation can be classified according to the Boston Ball Prep scale on a scale from 0 to 3. 3 is the best preparation, where you don't see any stool, with excellent visualization of the mucosa. And ascending colon, transverse colon, and descending colon are rated from 0 to 3. And as you can see here, our ascending colon preparation was 3 out of 3. Transverse colon also looks great, again 3. And descending colon, as you go down, you will appreciate that the patient had excellent prep. Total Boston Bowel Prep scale is 9 out of 9. Only with that type of scale will you find sessile serrated polyposis or flat lesions. So as we come down the transverse colon, it's important to suction all the fluid, as polyps can be hidden underneath the fluid. It's also important to examine not only the lumen, but for flat lesions, you want to go round and round along the wall of the colon, looking at the vascular pattern and also the innominate grooves. Anytime there is a disturbance in the vascular pattern, as you can see here, the vessels basically disappeared under this large flat lesion. This is sessile serrated adenoma number 5. So it's important to take time and define the lesion. Look for any advanced features like dysplasia, which you could suspect if the sessile serrated adenoma has any uneven, knobby, or nodular surface. So we decided to mark this site with a tattoo about 3 centimeters distal to the lesion, using a saline bleb followed by injection of a little bit of sterile carbon particles. And you don't want to inject too much to avoid the tattoo going underneath the lesion and make it more fibrotic, secondary to tissue reaction. And it's also important to take a photo of the tattoo and its relation to the flat lesion. That's how you take a photo, and when you do that photo, it helps your colleague identify that easily. So now we see another flat lesion. This is sessile serrated adenoma number 7, and I want to mark this with another tattoo here. Although one could say that there is already one tattoo, why not use that as a reference? And that's also reasonable. These are large flat lesions, and in my plan to resect these lesions, I want to not waste my time trying to search for them in the future. So that's the reason I'm putting this tattoo. So again, small amount of saline injection followed by injection of the tattoo into the blood. So again, we're taking a photo in relation to the tattoo. So as we come down, we reach the splenic flexure. So these last two lesions are located in the distal transverse colon, and here you see the vessel disappears under the flat lesion. So as we come to the splenic flexure, there's a pool of fluid. Again, important to suction that and examine the underlying mucosa. So as we come down and go past the splenic flexure and enter the descending colon, we are now on the left side of the colon. Ascending colon is on the right side of the colon. So we are examining along the walls, flattening the folds with a cap, and looking at the vasculature, looking at the innominate grooves, and looking at any subtle changes that happen on the folds. That's how you can pick subtle lesions. Otherwise, there's a good chance that these flat lesions that we have seen could be overlooked. So here is a tattoo that was placed by the second colonoscopist before she was referred here to mark this large lesion in the descending colon. So this is also another flat lesion. This looks like a little bit of an adenomatous appearance. We actually removed this large flat lesion. It was technically challenging. It took almost 2 hours to resect this lesion. And when we resected it, it had a component of sessile serrated adenoma and a villus component, or you could say sessile serrated adenoma with a high-grade dysplasia. This is occupying at least 40% of the circumference, and this was marked by a tattoo. This tattoo was useful in figuring out where the lesion was. Whenever you see a lesion on the right side of the field, that becomes technically challenging to resect if you could not rotate the scope and bring the lesion either to 6 o'clock or to the left side of the field. So now we find another sessile serrated adenoma. This is sessile serrated adenoma number 9, a little bit down from the previous large polyp. Again, another flat lesion. As you can see here, nice vascular pattern, and then there's a little bit of fluid. We are suctioning the fluid. And I would like to make a comment here. This is an unedited video of examination from the cecum to the rectum. The only segment that I edited out is the time taken to put the tattoo. So from about 22 minutes to 18 minutes and 47 seconds. Otherwise, you're seeing continuous examination of the entire colon from the cecum to the rectum. So we're coming down the descending colon. Again, it's very important not only to examine the walls, but to go up and down, move the folds, and examine. Here it looks like there's a little bit of a scar from previous resection. There's no recurrence there. That's good. And then we are suctioning the fluid. And here you notice that the colon is becoming a little bit narrower. The folds are at closer intervals. And we are entering the sigmoid colon. As you can see here, what I'm doing is I'm moving to and fro and round along the walls. And that's the best way to examine the colon, basically for subtle flat lesion detection. And if the bile is a little bit thicker, or there's a little bit of mucus, you could clear that with the help of a water jet. So as we come down the sigmoid colon, one could consider putting the patient from left lateral position to supine position. That allows the patient's colon to distend better, because in the left lateral position the air and CO2 distends the right colon, that is on the right side. When you are left side down, the right side is not dependent, the gas goes to the top. If you want to change the flow of gas and distend the left colon or descending a sigmoid colon, you need to change the position of the patient from left lateral to supine or right lateral position. Just now you have seen another sessile serrated adenoma in the sigmoid colon, number 10. So as we are coming down this sigmoid colon, we are using the cap to distend and examine in between the folds. There's a little bit of diverticulosis, pretty minimal. And as you come down, you will see a nice large diverticulum here. That's the mouth of the diverticulum, opening up with the cap. As we come down here, from the sigmoid colon, you see another small sessile serrated adenoma. This was probably less than 5 millimeters. This is sessile serrated adenoma number 11. And then another small one that you saw below, that is sessile serrated adenoma number 12. So we're almost coming to the end of the colon and reaching the junction between the rectum and the colon, that is rectosigmoid junction. And now we are seeing a little bit another flat lesion. This looks like more like a hypoplastic polyp. Hypoplastic polyps, serrated adenomas, they're all put together as sessile serrated polyps. So in total, in this patient, we saw over 10 sessile serrated adenomas. And we just resected the large flat lesion in the descending colon and during this examination. And here you see a tubular adenoma. So it's important to screen the colon so that you have a better idea of the total disease burden before jumping and doing an endoscopic resection. Thank you.